This week on the BackTable podcast.
So I always tell patients that trigger points are really good when there's a flare or when we're trying to figure out what's going on. We're not sure where the pain is coming from. I think it's musculoskeletal. Let's do this as a diagnostic block to see if we can get that area to become numb, to not become actively painful. And if you get relief, we can really target therapy to that musculoskeletal etiology. This is going to require some form of physical therapy. If it's a pelvic floor issue, pelvic floor physical therapy is really part of this. If it's an abdominal wall issue, you can see a physical therapist as well, or we can do some scar tissue release. We can really target that area with topical treatments, Voltaren gel, lidoderm patches, etc., and some good stretching and mobility. But the point is that the trigger point injection itself is short acting. And then we have to start doing the other therapies to try to rehabilitate that area and get it better and back to normal.
Welcome back to another episode of BackTable OBGYN. This is your host, Mark Hoffman, and we've got another great guest with us today, Dr. Aakriti Carrubba. She's a MIG surgeon at Mayo Clinic, Florida. She's a consultant. That's what they call you guys down there. And she's the associate program director for their MIGS fellowship. So, Aakriti, welcome to the show.
Thanks for having me. I'm excited to be here.
No, we're excited to have you. And we're going to talk a little bit about pelvic pain evaluation, but also how are we educating our trainees in pelvic pain. And so, as we like to do with all of our shows and for all of our listeners, we like our guests to sort of give us a little background on how did you get to be doing what you're doing? Sort of what was your backstory here?
Yeah, sure. So I grew up in Louisville, Kentucky, and that's where I went to college and medical school at University of Louisville, and moved out to Colorado for my OBGYN residency at University of Colorado in Denver. And after that, I moved to Jacksonville for a 2-year MIGS or minimally invasive GYN surgery fellowship at Mayo Clinic. It was a really great experience. I worked mostly in the operating room with different surgeons from GYN oncology, urogynecology, and MIGS. So we got a really kind of well-rounded gynecologic surgery exposure. And really during residency and fellowship, developed a lot of interest in managing pelvic pain patients as it kind of comes with a lot of the patients that we see for endometriosis and other gynecologic conditions. So I graduated fellowship in 2020 and stayed on staff and became a consultant here at Mayo in Florida. And during that time, also picked up a lot of different roles in education. I'm our site director for the medical student clerkship in OBGYN, so I do a lot of education at the medical student level, and then also the associate program director for our fellowship, so doing a lot of teaching at the fellow level as well. So in addition to the clinical practice and the patients and managing that aspect of things, I do a lot of teaching, and I think that there's a big intersection of those two things, especially when it comes to pelvic pain.
So, fellow Kentuckian, so nice to see.
I see that.
Even though, we have a friendly rivalry. I've got such an affinity for Paya and whatever they're doing over there. All this stuff. And Sean Francis, they have a great group over there. Can't say I like the basketball team, but otherwise. And then you were in Colorado. When did you graduate from residency? Was Leslie Apia out there by then?
Not yet. No, 2018. I've heard of her, but I haven't met her, actually.
She was at UK and then Ohio State. Okay. And now she's
great.
Got a new role, I think. So I think she's either leaving or left Colorado. So it's okay. So these MIGS fellowships, and as a fellow MIGS grad, there is increased standardization in the education of our fellowships, but it's still pretty variable, I would guess. I guess maybe that's more of a question. And I say that because in Michigan, where I trained, there was a heavy chronic pelvic pain focus. And, some it's heavy endometriosis, some it's heavy fibroids, some it's a combo, but some of the programs are pretty focused on pelvic pain. Was your fellowship pretty pelvic pain heavy?
Actually, not as much as some places like Michigan. I know UNC has a very heavy pelvic pain presence as well. Mine really wasn't. It was more of something that I became interested in as I was seeing these patients and really saw the need to develop that education. So our fellowship is really surgical focused. Our fellows spend most of the time in the operating room, sometime in the clinic, of course, but really learning how to become excellent surgeons. But when you get into practice, that's only part of the job. We have to see these patients in the clinic and talk to them and manage expectations, which is probably the hardest thing, I think, because we really want our patients to get better. And that may not just be related to the expertise of the endometriosis excision surgery, right? There's a lot of other variables that go into it. And I think that's where I really developed the interest, was in that interpersonal relationship and talking to patients. And some patients who'd had surgery already and said, you know what, I'm not better, or I'm still experiencing this symptom, and what else is there? And so as I saw more and more patients and really looked into this area and did research and met people at conferences and meetings and attended webinars, that's kind of where I really developed that interest, because I feel like you can really improve quality of life by getting into it more than just the surgery.
No, and I don't think there's a right answer here, but I do think that the variability leads to sort of differences in practice. And I think that at Michigan, I was always like, man, am I operating enough? I mean, we spend so much time in clinic and so much time understanding or trying to learn about understanding chronic pelvic pain. But I also sort of felt like that's where we're spending most of our time. And like the decision to go to the OR is like the most like doctory part of what we do. I mean, we want to operate, and anyone I learned that interviews at Michigan, apparently I have like the highest case volume of the fellows. So I guess I should feel okay about that. But yeah, I mean, that's the part where surgery is a treatment option. It is not the only treatment option. And oftentimes it's not the treatment option that provides the outcome that they want, which is improvement of their pain. So give us a little sort of like overview of how you address patients who come in, with the initial presentation for just chronic pelvic pain.
Yeah, absolutely. First of all, I think the most important thing is setting the stage and making sure that you have the time to listen to the story. Many of these patients are not coming to see me as the first person. They've seen other providers. They've been to the emergency department, maybe their primary care provider, maybe other OBGYNs. And the kind of common theme that we see is that they want to tell their story and have someone listen to them and kind of help come up with a decision really that's together, that aligns with their goals, and not to feel dismissed. So the first thing that I do when I see a new patient who's coming to see me, first of all, I acknowledge, I see that you're coming to see me with dysmenorrhea, painful periods, and from my review of your records, it looks like this has been going on for a long time. Kind of acknowledging that I've reviewed things, I know the story a little bit, but also that I want to hear it from the patient's own point of view.
It's amazing how much the feedback I get from patients that you're the first person who's ever really listened to what's going on. And sometimes you're the first person that's ever believed me. And I think it's part of our sort of, and we can talk about this a little bit, but sort of the challenges in our diagnostic tools. And then I also want to get into, like, as we're going to get into training and education, just, I didn't get a lot of this stuff in residency. Like maybe none. So anyway, yeah, it's important just to say, this is a subjective thing. I'm going to listen to you. And then I'm just going to say, okay, I believe you're in pain. And like, that simple thing can be world changing for folks sometimes.
Yeah, it really establishes a relationship in that, yes, I know you have to tell the story again to a new face. I'm sorry about that. But I actually want to hear what you have to say. I'm going to listen to you, take notes, ask you questions, not, be kind of rushing things to get to my agenda. I really want to listen to what you have to say. So I think setting the stage and setting enough time aside is really important for that. So we really try to do that for these new consults. Also trying to make sure that we have time set for, an exam if that's indicated, and then for the counseling part. Because what I want that patient to leave with at the end of that day is some sort of a plan, an action item. We're going to do X, Y, and Z, and then we're going to see, regroup and make the next steps. Because I think that really helps wrap up things for the patient and feel hopeful at the end of that visit, which is what a lot of these patients really are looking for.
You talked about time. So I have a couple of questions about that. One is every clinic's set up a little differently. I know Mayo is probably a little unique. So talk to me about how your clinics are set up and how much time you get with your patients, your new and your returns, and how you're able to get time or give time to your patients.
Absolutely. So I really try to kind of pre-review the new patient information as much as possible, really looking at that outside record so that I know a little bit about what brings that patient in kind of ahead of time. That really helps. I do have 60 minutes set aside for the new patients with endometriosis and pelvic pain, which is great. I advocated for that for a while, finally got it. And it's really hugely helpful. It allows for us to not feel rushed and get what we need. And there are some visits that go over that. I had a patient recently that spent an hour and a half with and, put me a little bit behind, but that was really what she needed at that moment. I do offset that by shorter kind of return post-op visits or pre-op visits. We shorten those to kind of still allow for that amount of time. But I really feel like it's actually improved the quality of the visits, and it's reduced how many return visits I then have to schedule just to simply talk about the same thing that I didn't get to at the beginning. So it's been beneficial. We've been doing it for about a year, and I've been pretty happy with the way that works. And I think patients are too, especially Mayo Clinic is a big destination center. So most of my patients aren't local. They have flown in, driven in from far away. And so I really want to make sure that, if they've made that effort, that I'm kind of showing that I appreciate that and I want to give them the time.
No, I think that's a big deal. And I was going to ask you about that because I know that some of the bigger centers like the one you're at are a destination center. But what I found even at UK, Kentucky, Eastern Kentucky is an underserved area. And I have folks driving 2, 3, 4 hours to see me for visits as well. And so the other thing I wanted to talk about was just as a MIGS provider, as a pelvic pain specialist, like you're not in a clinic with 30 OB patients. You're not in a clinic with like 40 return OBs, like, churning them through. And then all of a sudden this one patient with a complex problem comes in. Now, if that's your clinic, that's extremely disruptive.
It's very difficult.
There's no winners there. You're not winning in your clinic. Your team's not winning. Your patients, most of all, they're not enjoying that situation. We talked about your patient that lasted a little bit longer, but it took me a little while to figure out that I was trying to be on time, make sure everybody was seen on time. And then I finally got to a patient late and I was, apologizing. And she said, "We don't care when you get here, but when you're here, we want your attention." I was like, "Oh." So I just slowed down. I just okay. If we have to go long, and it all averages out, you have a couple, like you said, post-ops and things, but just really being present, really sitting with your patients, give them time, really seems to improve our opportunity to have that relationship. And like you were saying, so it is tough though. I think in a clinic, if you're not doing this a lot, it's really tough. It's overwhelming. And I think it's overwhelming for those of us that do it a lot, but tell me a little bit about your process. Somebody comes in, like you said, most of these are patients who've been seen by primary care or general OBGYN who's had pain. They tried some stuff. It's not working. Like, what's your sort of approach to those patients?
Yeah, I think the most important thing is getting the history and really identifying what symptoms they're having, when it's happening, all the factors that go into pain flares, pain relief, what's worked and what hasn't worked. A lot of times, the differential diagnosis for chronic pelvic pain is huge. I think a lot of times patients come in because they have pain and they say, "I think I have endometriosis." And many of them do, but also many of them have other things that don't really fit that criteria, or they've been evaluated for endometriosis and really don't fit that. So listening and talking through the, symptoms and what's worked, what hasn't worked is so important. And then I always try to get some imaging done too. Again, with the destination center, we're trying to get those things done at advance or at the same visit so we can review those, whether that's MRI or ultrasound or something. So I have something to go off of so we can review that as well. And then a pelvic exam is so important. And this is actually what I wanted to talk about when it comes to teaching. Because when I say that I'm going to do a pelvic exam for a patient, I'm not saying that we need to do a pap smear and a speculum necessarily, and that's the pelvic exam, right? There's so much more that goes into it, and actually so much more that you can identify about patients' pelvic, abdominal, low back, SI joint, gait analysis from just doing observation. And you can really identify that, well, you may have endometriosis, but you also may have, abdominal trigger points or pudendal neuralgia or some sort of other issue that an imaging test isn't going to show us.
No, and the physical exam is something that, talk a little bit about the difference between, I don't necessarily need you to go all the way through, you're welcome to do that. But just that in general, like how you discuss that, because it's not the same, right? I mean, what pelvic pain exam versus just like you said, I've had those before. This was different. Like, okay, well, what was different about it?
Yeah, and I think it's really being, systematic about anatomy. If a patient tells me that she has a lot of abdominal pain and, it's right lower quadrant, or a lot of times patients will say, it feels like my right ovary hurts. That's a common sort of thing that we hear, and maybe their ovaries are normal on an imaging test, and really we're not seeing anything that would indicate that there's an endometrioma or a mass or a cyst. A lot of times I start with an abdominal wall exam. You look for previous incisions, scars, you look for trigger points. So we actually kind of assess, tell me where your pain is on your abdomen. Let me palpate that area. We do something called a Carnett sign, which, you're probably familiar with that, where you actually ask the patient to kind of flex the abdominal wall, see if that area is tender, more so when they're flexed versus relaxed. And you can really identify more of that musculoskeletal trigger point. A lot of times patients have had C-sections and kind of just lateral to their phalansteal incision. You can see exquisite tenderness. And a lot of times you start thinking about nerve entrapment or irritation in that area. And this is never going to show up on a CT scan or an ultrasound. It's just going to be simply asking the patient the questions and then doing an assessment and documenting that. And then also, most importantly, be able to explain that to the patient. I've had patients who have suffered with abdominal wall pain for years. I actually had a patient who had a C-section like 20 years prior and said that she'd had abdominal wall pain for 20 years and was miserable and was asking, I need a diagnostic laparoscopy to evaluate this. And she had kind of classic findings of an ilioinguinal nerve entrapment syndrome. And we did a trigger point injection right there in the office, the first visit. And she said, I haven't had zero pain like this in 20 years. And she walked out of the office without pain. And it's really incredible to be able to do that. You have to be able to explain that to the patient, but then that kind of diagnostic and therapeutic block is really great as well, because it builds even more confidence in that relationship between patient. Then she said, okay, if this pain comes back, I know what to do. I feel like there's some hope.
So talk to me about trigger point injections. That's something that we did a little bit, but that's also something that I think there is different sort of formulations. And then in terms of what are expectations, like how do you know it works? How do you know it doesn't work?
Yeah, I mean, trigger point injections are essentially, trigger point is a tender point. You can do that in type of injection in the pelvic floor. So your levator ani muscles, obturator and turnus muscles. Like I just mentioned, abdominal wall. You can identify certain areas where there's classic, nerve, like ilioinguinal, iliohypogastric nerve innervation. Sometimes right around the laparoscopic port sites, patients will have a lot of tenderness. So identifying that type of thing, first you have to find out where the trigger point is. You really have to feel confident that is a musculoskeletal etiology, right? As opposed to a deeper visceral pathology. A trigger point is not going to be able to do anything there. There's lots of different ways to do it, and there's not a lot of strong data on which medication and steroid or no steroid. Normally, I use a 0.5% ropivacaine. We have that in our office. It's stocked. It's easily available as long as patients don't have any kind of allergy or adverse reaction to a local anesthetic medication. They're pretty good candidates for that.
So just that alone, you're not doing like
just
Kenalog.
That alone.
Okay.
Typically for the first one. I will sometimes add a Kenalog, 40 milligrams per milliliter, just so one single milliliter added to that. If the patient has shown benefit from it before, but maybe looking for a slightly longer steroid action, an anti-inflammatory action. You do have to be careful with steroid patients with diabetes, or you don't want to be doing steroids all the time. You have to watch the interval and the frequency of those injections too. Ropivacaine injection is a pretty safe one to start with.
What can patients expect in terms of, so it's great, I've not felt no pain in that area in years. How long is that going to last? What's long-term management in these situations?
Yeah. So really the more important thing is the expectations. These medications are short-acting local anesthetics. They are going to wear off within 8 hours, definitely by the next day. The action of the medication is wearing off. The benefit is interrupting the pain cycle and really relaxing a contracted or painful muscle and allowing for some rehabilitation to start. So I always tell patients that trigger points are really good when there's a flare or when we're trying to figure out what's going on. We're not sure where the pain is coming from. I think it's musculoskeletal. Let's do this as a diagnostic block to see if we can get that area to become numb, to not become actively painful. And if you get relief, we can really target therapy to that musculoskeletal etiology. This is going to require some form of physical therapy. If it's a pelvic floor issue, pelvic floor physical therapy is really part of this. If it's an abdominal wall issue, you can see a physical therapist as well, or we can do some scar tissue release. We can really target that area with, topical treatments, Voltaren gel, lidoderm patches, etc., and some good stretching and mobility. But the point is that the trigger point injection itself is short acting. And then we have to start doing the other therapies to try to rehabilitate that area and get it better and back to normal.
Is this something that if patients are coming from far away, you just tell them, hey, follow up with your primary doc to get these injections or find someone that does it? And the other thing is that's similar sort of with pelvic floor PT, like a lot of people don't have access to it. And so we wrote a lot of orders, and it's certainly gotten to be more available than it was 10 years ago. It's much more common, but I feel like I'm sending like most of my patients to PT. I mean, I know that
sure.
Finding some musculoskeletal etiology, like you said, it's history, right? Pains every day, worse with activity, more I do, worse it gets. At night, it feels like I got beat up. And of course, it's painful, but almost worse afterwards, right? And so having to sort of split up the different things into buckets. And so I think that's one of the things that's harder and harder for folks to understand is like, and also to understand they've had pain for a long time. Like they want something done now. And of course they do. Who wants to be in pain a minute more? And so, hey, this is the thing you've had for years. It's going to be some time.
It's going to take years to work on it. Right. Yeah, it's expectations. I think that when patients come to see you and they've had years of pain, what we need to do is listen and kind of give a game plan. And again, if they're not local or, coming from far away and coming to see me every 6 weeks or every 3 months for an injection is not feasible for them, then it would be great if they had a local provider who would be comfortable doing that. Now, a lot of pain management providers are doing therapeutic injections. Here at Mayo Clinic, we have a really excellent pain team. They do image-guided pudendal nerve blocks, ilioinguinal and iliohypogastric, ultrasound-guided injections.
Is that interventional pain?
Yeah, interventional pain, and even coccyx trigger point injections for coccydynia. So we're really doing a lot with our pain team here. And I know that can be the case in other places as well. And again, that goes back to the education. I want to teach my fellows and how to do these injections so that when they go out into a community to start their practice, they know how to do this assessment and the intervention. And I think really this comes down to, like you said earlier, in residency, general OBGYN residency, this needs to be a really core part of the curriculum, the exam, and then the treatments as well.
Yeah, I mean, I think the first pelvic pain exam I ever did was in fellowship. And I would say that in our residency program, I mean, there are a few of us that do it, but not consistently. Certainly not the way I was trained. And, the book chapter I wrote with Susie and all that stuff, right? Like it's pretty available out there. There's a million papers with this stuff, right? But it is something that you learn a ton from. You get a lot out of it. There's a lot to learn from these exams for sure. And you mentioned sort of the lateral pain points and entrapment of nerves, but also like endometriosis nodules and the C-section scar. I mean, that's always like so much fun to find because it's like, I knew it. Their history, and you lop it out and they're like, fine, this is great. Or you see it on MRI and it's like, fun to see. Talk to me about nerve entrapment though. How do you guys address that? Is it surgical? Is it injection? Like how do y'all address that?
For me, it's injections. I don't think that, especially if it's a remote injury from years ago, a lot of times there's nothing to see surgically, especially with those superficial small nerves. Now, right, like you're talking about a major nerve like an obturator, absolutely that needs to be repaired and that sort of thing. But if we're talking about the superficial ones like ilioinguinal, iliohypogastric, a lot of times there's not much to do surgically from my perspective. So I do a lot of the, like I said, abdominal wall, physical therapy recommendations, and the injections. I think there's some newer data, and this is where I refer to our interventional pain colleagues talking about cryoablations and other types of things like that, where they actually will go in and ablate the nerve either with like a cold therapy or alcohol or something like that. I don't know what the data is on that, but I think there are some options. Now, when it comes to pudendal and things like that, it's a lot more challenging because they really don't do a lot of cryoablations at our institution or offer those things for pudendal because of the location and its effect kind of on nearby structures.
Yeah, I actually don't know if we do that here or not. I'm not sure. We've got a good interventional pain group, but I'm just not sure. I've seen one patient, a colleague referred, had had come back, had surgery elsewhere and came back and had just had surgery. And the pain was just so specific right at the lateral port side. And they had closed the lateral port side. They made a 10 millimeter lateral port side, which I never do.
Closure. Yeah.
For those reasons. So I only make my larger ones midline so I can extend them and I don't entrap nerves. But then we went in there, found the stitch, cut it out, then immediately woke up. She's like, it's gone. The pain is gone.
That's great.
I mean, it was like the only time ever. It's not, like you said, it's not a common thing, but it was right after surgery. If you can get in there right away and cut that stitch out and redo it, that was very, very satisfying as a surgeon, because you could actually go in there and just very quickly solve the world's problems.
That's always the best. Like you said, the abdominal wall nodules too, those are quick fixes a lot of times. So it depends on the patient and the issue. And that's really where it comes down to it, is trying to evaluate that and do the right thing.
I want to get into the education and the training, all that stuff in a minute, but I also want to just get your opinion, since we're going down that road, on or just surgery for chronic pelvic pain. It's such a big topic, and we could probably have you back on and have like an entire separate discussion on that. But like, the further, and I'm 13 years out, and I'm also less clinical than I used to be. So I'm always curious what, the folks like you that are busier and younger and more close to your training, like, the longer I do this, the less confident I am that laparoscopy, the fourth or fifth laparoscopy is going to be the thing that makes a difference. And, I feel confident in our surgical abilities, in our teams, in our system. And we've built things in a way that I think is very, very patient-centered. And, I don't think we're like missing something. I just think, unfortunately, a lot of the problems that patients present with in my clinic at that point is oftentimes medical management is the thing that's likely going to provide the most benefit. Are you seeing that in your clinic? Or talk to me a little bit about sort of how you view surgery in the management of chronic pelvic pain.
So great question. And I really think this is something that we need to talk about more as a surgical gynecology field. So you see a lot more of this in the pain psychology literature. And I'll introduce the topic a little bit. We can talk more about it if you want. But essentially, I think you get a certain subset of patients that have chronic pain that's related to a pathology, let's say endometriosis or adenomyosis. And you can correct that, remove the pathology, and then they improve, right? We've seen those patients, and those are, the best stories, because they'll tell you, I had this pain with bowel movements, and periods are really terrible. You address that surgically, they get better, and you don't see them again because they are better, or they come back for an annual visit 1 year or 2 years later and say, I'm still doing fine, right? Then you get the subset of patients that has endometriosis, has a lesion. We've addressed that surgically, removed it. They get better for 6 months or maybe shorter, and they're still having pain. And you treat them for pelvic floor tension myalgia. You treat them for painful bladder syndrome, and they're still having pain. And every intervention that we offer, you get kind of worse or minimal improvement, right? So these are the patients that absolutely still have real pain, by the way. But what I think we're seeing is a lot of that central sensitization and that kind of chronic pain syndrome, where you get this dysfunctional pain pathway. So essentially, patients have this hyperresponsiveness of the central nervous system after years and years of experiencing pain. Everything becomes on red alert. So doing a surgery, might help a little bit, but it doesn't help to the same degree, because everything is more responsive to a smaller stimulus. These are patients who, really struggle with other areas of pain. Often these are the patients that have chronic overlapping pain conditions. IBS, interstitial cystitis, fibromyalgia is a big one. And these are all connected by the fact that these disease processes have a component of central sensitization. So when a patient, and I'll let you jump in just a second, when a patient comes to see me and has had 4 or 5 surgeries, has had a hysterectomy, I've looked at the pictures, I've looked at the pathology, there's really nothing significant going on there, and still has pain and has all these other hallmarks of central sensitization and pain catastrophizing, a lot of times I say another surgery may not be the best thing. In fact, that might even be a harmful thing for you. Let's talk about this other aspect of chronic pain.
So how do you approach management? I guess I'll have 2 questions, but the first would be like, how do you approach patients in whom you suspect central sensitization? Is again, is it, like you said, pain psych? Is it PT? All the things we do, plus
All the things.
are you adding neuropathics? Are you doing things, are you referring to other specialties? Like how do you manage that?
First of all, the hardest conversation is talking to the patient about what I think is going on, right? Most patients are coming to see us because they have heard that we are good endometriosis excision surgeons, and they're expecting us to say we're going to do an endometriosis excision surgery, right? And sometimes that's appropriate. And other times, like I said, I really get the sensation from talking to that patient that it might not help. So there's actually some screening questionnaires that you can offer your patients to really try to identify if they meet that clinical criteria of central sensitization. It's a clinical diagnosis. It's a diagnosis of exclusion. So you really need to make sure that they meet that criteria. So one is the Central Sensitization Inventory, or CSI, and the other one is the Pain Catastrophizing Scale, or PCS. Both of these are available online. They've been published. They've been validated. In our EMR, they are available as questionnaires that we can actually assign to patients to take. And there's a different scoring criteria. Essentially, if they score greater than 40 points on the CSI, that indicates a component of sensitization, versus less than 40 points is normal. And then with the PCS, I believe the cutoff is greater than 30 points. And it asks things about, quality of life, rumination, how much perseveration of the pain is there. So there's different questions, not just the pain, but kind of the whole picture of the patient. So a lot of times you can use that to try to identify if that patient meets criteria. And then the hardest part is the conversation to really say, while maintaining the relationship, I believe that you have pain. I believe all of the things that you're telling me, it is real pain. But part of the issue is not an endometriotic lesion in the peritoneum at this point. Part of the lesion is the fact that you have this kind of, the baseline pain threshold has gone from here to here to here to here to here over the years that you've lived with this pain. And at this point, we have diminishing rewards from doing the same laparoscopic surgery that you had 10 years ago. So we really need to kind of come at it from a different approach. So I really try to engage the patient in this and say, I'm not saying that I don't want to do surgery for you because of what you're telling me. I just don't know if surgery is going to be as beneficial now as it was before because of this other component of your central nervous system. And I think we need to target that.
It is an interesting conversation to have with patients. And I talk to most folks about sort of their different practices, but like, you guys are salary at Mayo. Is there like productivity incentives at all, right? So like whatever you do, there's no impact. And I talk about this a lot with my learners, but also my patients. Like, we are productivity based, and many people you see will get paid more if they do your surgery than if they send you to PT. And I don't say that often, but if they're saying, oh, you just don't care when I operate because I'm like, no, you don't understand. Like, I'm telling you what is right, because the motivation for me, selfishly, because we have colleagues around the country who take cash for surgery and don't do long-term follow-up, and it's excision. And I can't decide if I should open up this can of worms with you, but I feel like this is like our language here, because this is this is kind of what we do. But the excision surgery is not something I learned in fellowship. I've see more and more folks doing it, but like, I don't feel like I'll ever be able to tell a patient, oh, we're going to get it all. Like, ever. There's always peritoneum left behind, right? There's always, I'm not taking the large bowel out. I'm not taking out, like, just doing diaphragmatic strippings just because, like, there's going to be microscopic disease. Like, the endometriosis is going to still be there. It likely progress without treatment. So, like, help me and also when you do all that stuff, like, we have, new nerves forming, and with reperitonealization and all those things. Like, it's not a benign surgery. Even if the surgery goes well,
absolutely,
what happens next? Like, how are you incorporating that, or if you are, into your practice? And every practice is a little different. And we talk about this just because we don't have great data, right? It's not that doctors are bad doctors. We don't necessarily know, but what's your sort of thought on this complete peritonectomy or peritoneal stripping, and with like stage 1 disease, are you going in there and just doing radical resections?
I don't personally do that. I do directed excision for when I see a lesion. Now, I go and I look at every nook and cranny. We start, upper abdomen, diaphragm assessment, liver edge. We look at the appendix, we look at the small bowel, Look at the pelvis, of course, uterus, tubes, ovaries, pelvic sidewall, left and right, pararectal peritoneum, anterior compartment, look all over the rectum. So I have a systematic approach. I always take a bunch of pictures. I have put all the evidence together for that patient and for myself. We keep it in the chart as part of the medical record so we can review that later if it becomes an issue or a question. But I don't do a full peritonectomy for all patients that come in for surgery for dysmenorrhea or suspected endometriosis. I will say that most patients that go to the operating room after I've seen them, done the consult, done the history, everything, and actually get to the operating room, 90% of them actually have endometriosis of some sort, right? Very few cases, there are still some, but very few cases are going to be a truly negative laparoscopy. I always do some sort of biopsy. Even when I don't see anything, I do typically biopsy or sample, near the uterosacral ligaments, pelvic sidewalls, but small specimens. I don't want to create more problems or create bleeding or anything like that. Some patients will need a bigger excision surgery. Others, because they have multifocal disease, others will just have a few spots in this one particular area. And that's what I target and do. And I think that for me has been a good practice where I'm not, taking on unnecessary risks. Because of course, every area there's going to be bleeding. You've got hypogastric nerves in this area. You have to have retraction. What if the ureter is closed on this end? I don't need to be increasing risks during surgery. I do what is necessary for the patient at that time. And then, there's always the question, is my endometriosis going to come back? I always tell patients this is a chronic disease, and I don't use the word cure. I'm not curing your endometriosis from this excision surgery. I'm managing it. I'm getting the diagnosis. We're excising lesions that aren't supposed to be there. We're allowing for healthy peritoneal tissue to grow. And then we're going to manage it going forward with, I do often recommend doing some sort of hormonal therapy, whether that's placement of a Mirena IUD at the time of surgery or progestin-only pills or some sort of thing to either not have a period or have a light minimal period, kind of have a more progestin-heavy environment. And then we see how they do.
And we have very similar practices. I think the data on hormonal suppression for endometriosis is one of the few things we have that's actually really good. And the number of people who are so openly opposed to using hormonal suppression, it's so weird to me, but of all the things we do for endometriosis, the one thing that I keep reading again and again and again is in patients that have a hysterectomy, for example, with non-endometriosis, you leave their ovaries in, rate of recurrent pain is 60-70%. If you suppress them, it's much, much lower. If you suppress them for 3 months and then stop, they join the other group shortly thereafter. It's not like it is a long-term chronic condition that we manage. I use the same exact word. We don't cure this. We manage it. Now we have really good data and really good tools for managing this disease better than we used to. And there's clearly much more work to be done.
Right.
But the number of people I see that have surgery and were diagnosed and we're never recommended to be on anything. It's like, what an opportunity missed, right? Like had you suppressed it then, there's a really good chance they wouldn't have needed to come see me at all. So that's something I'm still trying to figure out, what the counter argument is to, and this is not to say that patients have to do anything, right? Some don't want to do it, don't tolerate it, that fine. But to have GYN surgeons doing these surgeries and not at least discuss
recommending it. Yeah.
Yeah. To not at least say, this is something that can be helpful. That's always been surprising to me. But let's talk about how you teach your trainees, because again, going back to what I said earlier, I had no idea about any of this stuff. And I trained at a good spot. We're busy surgeons, did a lot of things at University of Chicago, but it just, there wasn't this practice there at the time. And, Michigan, it was like, whoa, this is like, I didn't know this thing existed. It's like, how is this still OBGYN? And we've talked about this on the show. I'll talk about this for the rest of my life. 4 years of training to be an obstetrician, which I think is hard. I don't do OB anymore and haven't for 10 years. And I don't want to. It's really hard and it's hard enough. And oh, by the way, be primary care doc. And that's, a whole other specialty that I think is really hard. And oh, by the way, be a surgeon. It's 15 months, I think, is the average amount of time that our trainees in residency are spending learning how to be gynecologists. And that doesn't mean 15 months like in the OR. It means 15 months on a GYN rotation, which can be pager holding and consult performing. And so, yeah, are we really dedicated to this, to teaching this stuff if in 15 months? It just seems impossible, because that's GYN, GYN oncology, urogyn, MIGS, all of it. it's a lot. So talk to me about how, so is there a med school in Jacksonville? Mayo has its own med school, or is it?
Mayo has its own med school, and we have a Florida track. It's a lot smaller. There's about 12 to 15 students at our Florida track. So it's actually nice because I usually have 1 or 2 students at a time on the rotation. So I really get to work with them closely. Obviously, every time they're working with me in the clinic, we're talking about pelvic pain and endometriosis, and they're watching me do trigger point injections in the office. And, we talk a lot about this sort of topic. And they listen to these 60-minute consults and they step out of there and say, whoa, that was a lot. So honestly, I think it's great exposure. We include this in our didactics education, which is tri-site with the Mayo in Rochester, Arizona, and Florida. So we're actually talking about these topics with our medical students: endometriosis, pelvic floor pain, all of those kind of things like that, and introducing the topics early. We don't have a residency program, so I don't have residents of my own, but we do have rotating visiting residents from our University of Florida, Jacksonville campus. So we do get the third years for about 2 months at a time. And it's nice because I get to talk to them about the same sort of things. And we do Botox injections in the OR, show them how to do it. We do a lot of education and teaching too.
Are the med students based in Rochester for like the first couple years and then they come down? I bet those are the lucky ones who get to leave Rochester, like the winter rotations. To go do your Florida rotation. That is probably a long waiting list.
There's some in Arizona as well. So the Arizona or Rochester for the preclinical, and then they'll elect to go to the Florida track. So yeah, it's probably a nice break.
They have a campus in Phoenix for the preclinical stuff too. Interesting. So yeah, talk about how, and you have 2 fellows?
2 fellows. Yeah. And so first of all, we do a pelvic pain education meeting quarterly, which is great. So we'll actually go over all of these topics. We'll have guest speakers like from pain medicine or from our pain psychology program. I didn't even get into that. For central sensitization, what do I do for patients? We actually have this really great program called the Pain Rehabilitation Clinic, which is a 3-week outpatient program from 9 to 5 in our pain management department, but it's run by pain psychologists. And it's mostly cognitive behavioral therapy in a group setting. So it's not just pelvic pain patients, it's any type of chronic pain patients.
Did you say 3 weeks, 9 to 5?
Outpatient,
but 9 to 5, all day, full-time job for 3 weeks.
Full-time job.
Who does this?
Patients. And they have great outcomes. And they can bring a family member or a support person, and they just come like a class and participate. And like I said, it's not just pelvic pain or GYN issues. It's migraines. It's chronic GI abdominal bloating or back pain or any kind of chronic symptom. We're also seeing a lot of patients that have these diagnoses of kind of chronic neurological symptoms that are, a lot of them have to do with that central sensitization component. So a lot of them are referred into this program. So it's kind of a mixed bag of diagnosis. And there's psychologists that are teaching classes, small groups, individual therapy. They have a gym, they do exercise and physical and occupational therapy. And also another really great option that they can do in this program is take patients who are on opioids and want to come off safely to kind of reduce their use and stop altogether. Because that's some of the hardest things. I have patients that have been on oxycodone for months to years, and they come and see me and they're like, I want to come off my oxycodone. And that's really hard. So it's nice when there's a program and there's somebody who's kind of monitoring that safely, making sure that they're not doing it in a dangerous way or having side effects or anything like that. So it's a really great option, but I think it works best when patients believe that it's time for that. Do you know what I mean?
It's a commitment. I think PT is a smaller version of that, but
right.
You have to be willing to say, okay, or not just be willing to say, okay, but have the time and have the luxury and the opportunity. Some folks work and just can't, or don't have access. So I don't mean to be judgmental here, but I think, but those who can, to say I'm going to go, I'm going to try, but because a lot of folks are just like, this ain't going to work.
For sure.
So I'll go do 1 or 2 and go, this is not working.
Right.
It's like me going to the gym once and being like, well, I'm not in shape. Gym's broken. You're like, well.
I didn't lose 20 pounds. What's going on? So they do FMLA for this type of program. So and they'll sign FMLA. It's now getting more and more covered by insurance. That used to be an issue with coverage.
I'm dying to
so it's
learn
kind
more
of
about this.
You can have a diagnostic laparoscopy that I don't know if it's going to help you, and I'll sign your FMLA for that. Or you can get your FMLA for this type of program, kind of come in and commit to that. And really go that route. So I offer it to a lot of patients. once we're there, meaning some patients, you can't bring this up on the first visit and say, oh, this is too much for me. I think you need to go there. Some patients will need to go there eventually, but I think developing the relationship, making a plan, and then building this into the plan when it's appropriate is really helpful. It's a great tool.
Wow. That's amazing. Something new I've never heard of. Doesn't happen very often.
So teaching, we're talking about teaching.
Teaching.
So teaching is, going over anatomy. We have excellent pelvic floor physical therapists that love to teach. They bring their model to our clinic and our conferences, and they show where the muscles are. And then we, have the resident or the fellow or the medical student, do an exam. They show how they do an exam in the patient, external visualization. We talk about visual inspection. We talk about palpation of the different muscular structures. And then, like I said, I do a lot of trigger point injections and Botox injections. So when they're working with me, we talk through those cases. They're seeing us do it. And it's nice because when they have their own continuity clinics and these patients come in, they're then getting to see that patient and do the same assessment. So I think it's all about just repetition and using different tools, whether that's a model, whether that's a simulator, et cetera, to teach that and then apply that when they're seeing patients on their own.
Well, they're very lucky. I mean, that's something that, again, it's also a blind exam, right? So I think one of the other things when you're trying to teach someone, like, did you feel that? Like, I don't know, I think I felt that. Like, it's hard to, and the patient's like, nope, they didn't. Like, they'll tell you, you were pushing on a different area. It's something you have to do a lot of. And as a former clerkship director, I was always, just the pelvic exam in general, I was like, why is this a requirement? Like, you're going to be an ophthalmologist. Like, you're OMFS. Like, what are we doing here? Like, we're checking a box. Like, you're never going to do one. More importantly, anyone who does one after this rotation, we have our residents, it takes 6 months before I can say I trust that exam. So why are we even telling people they should even do this? Like, never do one. That's actually the best thing that you could ever do, is never do a pelvic exam unless you're going to do a lot of them, because it's one of those things that, unless you're there's no way to prove that they're doing it. You just got to learn to trust their exam based on what you're feeling, what they say they felt, and those things. But the pelvic pain exam is again, times 10. It's okay, let's really get it. What are you feeling? Operator internist, are you sure you felt that? No, not really. But it is amazing when you're doing it and you can really reproduce their pain and show them this is where the pain is. Or the Carnett sign is something that is such a powerful tool for saying, actually, when you're using your muscle, it gets worse. And I think that's something that when patients are so frustrated because they've had all these things done, but imaging, it's not going to show up. Surgery, you put in the scope right past their abdominal wall. There's no abnormalities that are going to pop up in their abdominal wall or pelvic floor from surgery. Or in the pelvic pain exam, you haven't even gotten up to the female reproductive anatomy. You're still in the pelvic floor and their pain is this is it. I'm well, okay, just so you know, you've not yet touched your cervix and uterus, and your ovaries. Right. Your ovaries are miles away. And we know that that's my ovaries. I'm and they could be, right? I'm not going to tell you they're not. But what you're telling me right now is what I'm pushing on is, I can tell you it's not your ovaries, and that's what's hurting. And it's just, speaking of education for our residents, for our patients, it's just, if the docs don't know about it, you can guarantee the patients don't know about it, right? And that's, it is such a, going back to the first thing you said, a long time with patients, it is let's just spend time and do this and take our time. And then those notes are long. But by the way, we just started using AI ambient listening.
Game changer.
Whoa. Okay.
Game changer.
Whoa.
Let me tell you that I, for the first time, am finishing my notes before I leave the clinic, and I don't have to bring my work home with me. So
you know what they call that?
Thank you for whoever developed that.
So our Epic people can look and see when people are writing their notes, if they're writing them after hours, and they call that,
Totally.
It's an actual Epic metric, is pajama time, when people are writing notes, at home. The dramatic drop in pajama time hours for providers who use this. And
Thank you. Thank you.
It is
for whoever developed this.
I know. It's in better notes than I'm writing, let alone my students and residents.
No typos, no dictation errors.
And you're not forgetting stuff. So I always write my note right after I see a patient, because I've just, the data, if I don't write it right now, if I wait till lunch even, it's, my brain's who is that? And the data shows the one, you wait an hour, a half day, by day 2, you might as well just make it up. It's gone. And so I've always written them right then, but even still, you're kind of like, you're trying to be efficient and fast, and you're trying to like, shorthand a little bit. And the discussions are like, I can't write 25-minute essays on the discussions we had. So I have like a form, but it's not very specific to what we actually talked about. But this thing is listening. And then when patients go back and read the notes, like, no, that's what we talked about. Like, it's such, like, they were there. They heard us. I didn't make it up. And it's like, it really is, I said, it's not going to like just record us. It's not going to like take your lemon bar recipe and whatever. And like, that's not in the note when you go back and look. I mean, it really is. How long have you guys been using it?
We've had it for a couple of months. I started using it about 2-3 months ago when actually my colleague was like, have you heard of this? And I was like, no, tell me more. And it's great. I mean, we had a few snafus, like you got to make sure your Bluetooth is like not connected to your headphones. So, and then otherwise it like doesn't record anything. So I had a couple of days where I was like, this is terrible. But then once I figured out the technology
that you did not know existed 10 minutes ago, you're like, where is it?
But no, it's great. And I always tell patients, look, by the way, I'm reading the note and editing, and sometimes I'm adding, and then it never really records like the person's name, right? Like the surgeon's name. So I want to put that in. I reviewed the op note from this date.
Right. Yeah.
So I put that in. But I mean, it's pretty good. It cuts down my charting time significantly.
It's amazing.
And it's good because it has all the discussion, like you said.
Exactly what we talked about. And so, no, it is, I knew we were getting it, and I was like, well, I'll try. It's just one of those things like, and finally the other day I was in clinic, I was like, I'm just going to do it. And I was like, all right, well, I did it, but then how do I get it in my note? And I'm like asking like the med students, like, I don't know what you're talking about. So once I did it, I actually called my dad, who's like a retired internist, and I was like, dude, you practiced in the wrong generation. Because he used to like dictate like on like little cassette tapes. Then would have people have to go back and someone else would go type it out. And now it is
instant.
It is world changing. It really is incredible. And like in AI, we can say what we want, but there's some things that AI is going to be great for. But anyway, a little sidetrack there. I'm just so excited because I just started using it. And actually one of the people I know who's like, was talking to the urology department, and one of them came in late, and she was like, I'm sorry, by the way, I hate everything. AI clinics, note writing, best thing ever. Like,
yeah,
even the biggest, like, curmudgeons and, the folks that hate everything are like, this is great. So education. So I think, taking time, really, using models, like thinking about how we teach it is something that it's just not done, I think, for our basic training. So you did residency in Colorado. How much pelvic pain training did you get?
We actually had a couple of people who were really well known in the IPPS, International Pelvic Pain Society, that, were at my residency program. So we had pelvic pain clinic, but it was really hard. You're a resident, your pager's going off. You're supposed to sit and ask this really detailed form. They had this like PDF form of all the questions. It's 16 pages, and we had to kind of fill that out.
Oh, yeah.
I know. And I mean, I get the detailed notes, but like as a second year resident, to do that, I didn't get it at the time. I just don't think I understood.
You have so many things that are coming at you, and OB and all of it. And no, I'm with you. Like, unless you give it time and space, it's going to get lost.
And then I never really saw the patient back. Like, I was with that attending for one day. So I was like, I don't know what happened to this patient. What's the follow-up? What's the continuity? So I didn't quite understand. Now, these are my patients. I'm seeing them. They're calling me. I'm responding to the portal messages. I very much see that longitudinal, evolution of their symptoms. And honestly, a lot of this stemmed from the fact that, like, I cared about these people getting better, and I wanted them to get better. And I was like, what I have to offer, there's got to be something else. There's got to be more. So, I think it's partially the curriculum and the education, but it's the interest. And I think having a faculty member who's like, I'm really interested in this, and this is why I care, will also then get that next generation of learners to become interested in it and to care. And so, not to say that my attendings didn't do that, but I just think that giving it the time and the space that it deserves is important. Now, with the MIGS curriculum, there's a huge shift to including pelvic pain education which is great, in our standardized curriculum that goes out. It's a 2-year repeating source of like videos, articles, etc. So I'm actually on that committee with AAGL, and we've got chronic pelvic pain as a big topic. And then in the milestones that the fellows have to now accomplish, chronic pelvic pain is a big component. So
fantastic.
I think it's really becoming highlighted in our field, especially in the field of mix, because this goes hand in hand with all of the pathology that we're surgically treating. We have to be able to treat the other
They
parts of it
officially
too.
changed the name of MIGS yet? Is it? I know
You know,
Arnie had
I
said
don't
it was
know.
coming, like complex benign
gynecology.
GYN.
You know, it in some circles we refer to it as that. Some is MIGS still. I don't know. TBD, to be determined.
But I mean, MIGS is an approach, and like everybody does MIGS, right? So like, not everybody does what we do, but everybody does, some version. Yeah. So, and this is what the Urogyn folks said. It's not an approach. They're not vaginal surgeons. It has to be based on medicine and pathology. We have plenty of it. I mean, fibroids, endometriosis, pelvic pain, like we don't need more than that, right? But there is more. But like there's plenty there, and that's what I think focusing on that is going to help us, I think, have that it will become a boarded specialty. There's just too much there. There's too much need. It's just too complex, and I think that's something that I think I'm glad to see the evolution. It's a little bittersweet. I'm a CMO now, so I'm like 70% admin. So like my practice is kind of like this. So hopefully, as I've kind of moved away from some of that, you guys, it's always nice to hear people like you are really dedicated in doing this stuff. But the last thing I'll say, as a CMO, like what I'm finding in leadership is get people to do what they're interested in. Like don't try to make somebody interested in something they don't like. I can promise you, they're not going to be very good at it. They're not going to want to stick around. They're going to be miserable. Like, no, there's no winners here. Like, find the person that likes to do the things you hate doing. Find the things that they like to do that, don't make someone who's a busy surgeon be a researcher if they don't want to be. If they're curious about it, great. Support them. Give them whatever resources they need. But if someone like you is like, hey, I want to do pelvic pain, it's like, what can we do to help you get there? What resources how much time do you need? I mean, these are, diamonds in this world. Is just, someone who genuinely cares, who's good, who can do it all. So they are so lucky to have you down there. It is, I love hearing how.
Thank you.
No, I mean, how curious you are about it and how much work you put into it to build this thing that obviously you've got great partners, but also to say, this is the thing I'm going to do, I'm curious about. And then you become great at it, not because you are some type of, successful person, which we all are, but no, because I really am interested in it. And by spending my free time, my time thinking about this thing that no one else does, I'm going to provide something for patients that others can't. And that's a really, really great thing. So they're lucky to have you in Florida. This has been super educational for me, and hopefully, or I'm sure our listeners will feel the same way. We really are grateful for your time and expertise, and it was an absolute pleasure to have you on. And hopefully I'll see you in Vancouver.
Yeah, I'll be there.
Awesome. All right. Thanks again and have a good night.
Yeah, you too. Thanks.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Orgodzinsky.
Show notes and social media by Emma Landenwich
and Lindsay Beecham.
Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.